is Ann Silvis, University of Illinois Extension. Extension hosts these monthly conference calls, webinars, and we're really pleased this time to have a very high turnout. As I just mentioned a minute ago, we're muting all of the mics to reduce the background noise and static. If you have comments or questions, please use the chat box and we'll monitor that. Today our presenter is Heidi Clark. Really pleased that Heidi can join us today. She's the Division Chief of Health, Data, and Policy at the Illinois Department of Public Health. She comes back to us. She's been in California. She's been at Memorial Sloan Kettering in New York, and she came back to Illinois to head up the Division of Health, Data, and Policy. We're really pleased that one of the focus areas of Illinois Department of Public Health is the opioid crisis. So Heidi, really happy that you're here. We're looking forward to your perspectives on the state opioid crisis. So welcome, Heidi.
Great, thank you. Well, as Ann said, my name is Heidi Clark. I'm the Division Chief of Health, Data, and Policy at the Illinois Department of Public Health. One of the things that I focus on here at IDPH is opioids, and I help with our response to the opioid epidemic. I just wanted to say at the beginning, please feel free to ask questions at any time. Like I said, that's in the chat box on the left. I also saved some time at the end for any questions you might have saved until the end. I just wanted to give an outline at the outset to let you know what I'm going to cover throughout this. I'll start off with an overview of what it looks like in Illinois, what communities are most affected. I'll go through some terminology to make sure we're all on the same page when we are discussing these issues. Go into some background about the history of the opioid epidemic, and working toward a solution at different levels of government and community. And I say working toward a solution because I don't think any one thing that we're going to do will address this entirely. I also want to give a little disclaimer at the beginning. I'm not a clinician. I have degrees in public health and human biology. So anything that I mention about medical issues, please keep that in mind. And also, a lot of this has to do with law enforcement. And again, I've never worked in law enforcement myself, so I don't want you to think that I'm telling you how to do your jobs. Rather, I'm just sharing tools, experiences, and best practices that I've become aware of since working in the public health field. Next slide, please. So most of you probably are aware what opioids are. You've probably heard a lot about it in the news, and that's why you're on this call. But just to make sure that we're all, again, on the same page, opioids are a class of drugs that includes things like prescription pain relievers like Vicodin, Percocet, OxyContin, synthetic drugs that you hear about on the street like fentanyl, carfentanil, and heroin. And some people need opioid prescriptions. As I mentioned, I used to work in a cancer hospital in New York. I know firsthand the need for legitimate opioid prescriptions. And again, I don't want to demonize anyone who needs these for medical use. But when they're used outside of a medical setting, they can become a real problem, as we've seen in the state. I'll jump right into statistics. Data is sort of my bread and butter, so I can't do any presentation without leaving you with some graphs and maps. I tried to limit the number of numbers in here because I know not everyone loves seeing all of them. But just to give a background, in 2016, almost 1,900 people died in Illinois due to opioid overdose. That was actually a provisional statistic while I was making these slides. Right now, it's just under 1,950, and I expect that won't change very much. More people in Illinois died due to opioid overdose than to car crashes or gun violence. So you hear a lot about, murders in Chicago, or everyone knows about bad car crashes and fatal car crashes, but this is actually affecting more individuals. You can see in this graph, starting in towards the end of 2014, that's when we in Illinois started to see an increase, a real measurable increase in opioid overdose. There was some before that. It was a little bit slower, but towards the end of 2014 is when it really started shooting up. At least in this map, it shows a peak at the last quarter of 2016. We'll see what it looks like going forward. Just a note about the data, because of the way we record deaths in Illinois, using a coroner system rather than having a centralized medical examiner, there's a bit of a delay in reporting these deaths to the state. We're doing what we can on our end to speed that up, but when I talk about deaths, I just want you to be aware that we are a little bit behind on that. So now I want to talk a little bit about the non-fatal opioid overdoses in Illinois. I have a couple maps. I'm sure everyone knows where their counties are. I'm still new to Illinois, so apologies for not being able to name all of these. You can see the rate of ED visits for heroin and opioid analgesic overdose. And opioid analgesic just means the synthetic opioids I talked about, the fentanyl, carfentanil, and prescription pain relievers. That's all that title means. So when you look at those darker blue counties, those are the ones that have a higher rate of emergency room discharges. The next slide, I lost the connection again. I'll see if I can get it back. I got it back. Okay. The next slide shows the hospitalizations for opioid overdose, and it's just another indication of where is being hardest hit. Also, I want to point out that these numbers would be affected by where the hospitals are located and where people overdose. So it's not, there are some little intricacies with the data when you're talking about where they live versus where it happened versus where they sought treatment. So just keeping that in mind, it wouldn't change it that much, but these are the counties that are especially hard hit. And now, like I said, I wanted to go through some terminology. The first one that's not actually on that slide is tolerance. So you're probably familiar with what tolerance is, but tolerance to opioids can begin to develop as early as 2 to 3 days following continuous use of opioids. So if you're given a prescription and you're using it a few days, some people become tolerant of a certain dose very early on. Dependence is the physical adaptation to a drug that may result in withdrawal symptoms. Sometimes you hear some confusion between dependence and addiction. So addiction is when you've become, it's a chronic brain disease. It's when you've become not only physically dependent, but there are also biological, social, and spiritual manifestations. This is a definition from the American Society for Addiction Medicine. It's reflected in an individual pathological response pursuing reward or relief by substance use. And then the last one that I wanted to mention is what I use and what I will be using in this presentation, which is opioid use disorder or substance use disorder. It's the medical terminology that's included in the DSM-5. And just like it says above with addiction, it's a chronic disease, and I will be in here trying to make the argument for treating it as a disease and a public health issue. So a quick history. I often get questions, how did we get to this point? There is one, I have a couple. These are personal book recommendations. They're not necessarily what the department has said, but I found these especially helpful, especially Dreamland by Sam Quinones. It covers all of the aspects of the increase in opioid use in the United States. over time. So I would highly recommend reading that. It's a good read. It is not a happy read. American Pain is the second one, and that covers more of the prescription drug use, and it's a little more engaging, less history, but again, it's good for understanding the landscape. So just quick history. Heroin was first synthesized in the late 1800s, and it was actually marketed as a non-addictive morphine substitute. So there had been people who had become addicted to morphine, and they saw that as an issue, so they wanted to develop something to treat pain that was strong enough to treat major pain, and so they came up with heroin. Didn't turn out so well. It became illegal in the United States in 1920, and in the 1990s, there was a lot of Mexican black tar heroin that came into the United States that was lower priced, and it spread pretty significantly. In the early 2000s, there was an increase in opioid prescribing. The public, there was a lot of demand for it because there was a general feeling that pain hadn't been adequately addressed by physicians. In 2001, there was pain became considered a fifth vital sign. You'll hear this a lot when you hear the history of the opioid epidemic, and it's just saying that it's one of 5 major things that clinicians should be considering. So that led to a substantial increase in opioid prescribing. Then pill mills became an issue where people who had developed an opioid use disorder and no longer could get prescriptions from their physicians went to these clinics that were not entirely legitimate, and they were able to get large amounts of prescription drugs, which led to a lot of people becoming addicted to those. And then now, one of the things that's leading to an increase in deaths is the amount of synthetic opioids available. So if someone were to go out and try to buy an amount of heroin, there's a good chance that either they wouldn't receive heroin at all and actually receive fentanyl or a fentanyl analog, or it could be anything else. Or they would receive heroin mixed with one of those synthetics. So I try to describe this as sort of the perfect storm. Stopping any one of these things wouldn't necessarily have stopped us from getting where we are, but it might have made it not as bad. So just an overview. Oh, I don't know if people can still see it because I got an error message. Can you see the federal government slide?
Yes, we can see that, Heidi.
Okay.
Yes.
I will try and get my thing to work again. But so the federal government, I just wanted to let you know who is working on what. I'm not going to go into depth with the federal government. I don't work for the federal government, and I only know what they're doing in relation to what the state is doing. So first, there was a bill passed in the last administration called the Comprehensive Addiction Recovery Act, CARA, which provides funding to a lot of different projects across the country. We actually just received a grant from them through the Substance Abuse and Mental Health Administration, SAMHSA, to provide naloxone and care coordination in South Central Illinois. You've probably heard the news about the public health state of emergency a couple of weeks ago. I don't think there have been a lot of concrete steps after that, but it should reduce the burden to address some of these issues. And then I just wanted to list a few of the agencies or groups that are dedicated to opioid or other drug use. The first is the President's Commission on Combating Drug Addiction and the Opioid Crisis, the White House Office of National Drug Control Policy, which oversees the High Intensity Drug Trafficking Area Program, or HIDA, and then finally the Drug Enforcement Agency, or DEA. I can't advance the slides, so if one of you could take over.
We did.
Okay, to the Heroin Crisis Act?
Yes.
Great. So in Illinois, the Heroin Crisis Act, which is also known as House Bill 1 or Public Act 99-480, resulted in some changes to Medicaid and insurance coverage, leading to fewer barriers for medication-assisted treatment for opioid use. Also increased the availability of naloxone, which I'll talk about in a little bit, allowing health professionals to prescribe to people not personally at risk for overdose. So if you had a friend or family member that you were concerned about, you could get a prescription for naloxone. It expanded the prescription monitoring program, and there are some reporting requirements associated for coroners, DHS, and the Department of Public Health. Next slide, please. Do you see a graph or 369?
Graph.
Okay, good. So the first thing that they wanted to do, all of the agency directors in Illinois, along with the governor, wanted to create a state opioid action plan to address the issue in a comprehensive way. All of the agencies had been doing different things to address it. IDPH had our silo and DHS had their silo. And the plan here was to leverage all of our resources together to see what we can do. So the first thing they did was set a goal of reducing opioid overdose deaths in Illinois by 33% off of the expected amount in 2020. Next slide, please. There were 3 pillars, 6 priorities, and 9 strategies. You can hopefully see them on the screen, but the pillars are prevention, treatment and recovery, and response. And I'll jump down to the strategies. They're to increase prescription monitoring program use, reduce high-risk opioid prescribing, increase accessibility of information and resources, increase the impact of prevention programming, strengthen data collection, analysis, and sharing, increase access to care, increase diversion and deflection program capacity, increase naloxone training and access, and decrease overdose deaths after release from institutions. So I know that this webinar is focused on local communities and local governments, and a lot of these strategies actually can be addressed locally, and I'll get into that in a couple slides. So next slide, please. This is just an overview of what the local options are. It's really just to refer back to later because I go into detail in the next slides. Next slide, please. First, local coalitions have been addressing local needs for quite a while now in Illinois. It's important to engage a variety of stakeholders. I've listed some below. It's not an exhaustive list, but these are ones that we often see represented on local coalitions: law enforcement, judges, lawyers, faith leaders, probation, parole, public health, physicians, nurses, and so on. And it's, again, important to address the local needs. They may differ from county to county or even within a county, especially those larger counties. Next slide, please. I wanted to go through some of the treatment options since this is something that can be addressed at an individual county level or an individual provider level. But also I want to keep in mind that an individual must be ready to enter treatment. So someone who's struggling with opioid use disorder may not be ready to go into medication-assisted treatment, and forcing them to do so will likely not be effective. But if you have someone who's there and ready to enter treatment, there are 3 options for medication-assisted treatment. The first is methadone. That's been around for a long time, and you've probably heard of it. There's buprenorphine. Also, the brand name is one of the brand names is Suboxone. And those 2 have been widely studied, and they're very effective. Vivitrol is a little newer. The advantage of that is it's an injection once a month. So it's especially advantageous if someone is being released from a correctional facility. It prevents them from experiencing a high from taking an opioid. It hasn't been studied as much as the first two, but it has been successfully used in a lot of people. Wraparound treatment is the idea that there needs to be support making the medication successful. So if you think of something like diabetes, another chronic disease, there is people need insulin, right, to help treat it, but they also need to make changes in their lives. So the medication allows them to continue living while they make those changes. And some people will always need it, and some people won't. So I like to compare the two, especially, as I said, I'm trying to emphasize that this is a medical condition, not a moral failing. And again, remember, what works for one person may not work for another. Some people don't want medication-assisted treatment. Some people want to do a 12-step program, or they want to seek just individual counseling or group therapy. And if that works for that person, I think it's important to support them in their choices. Next slide, please. So one of the problems with medication-assisted treatment is that it is not available in a lot of the state. Prescribing for Suboxone requires special training, which is called data waiver training. So it's the Drug Addiction Treatment Act training. And then even after receiving the training, a lot of people do not end up treating patients with Suboxone. It's not just physicians who can become data waivered. It's also nurse practitioners and physician assistants, and training is available online for free. This is something that I think individual providers, especially, actually, can you go to the next slide? If you look at this map, it shows, especially in southern Illinois, there's a large sort of treatment desert. And within central Illinois, across the state, it's difficult for people who want medication-assisted treatment to get it. But this is something at an individual provider level that people can decide to take the training and offer with the support of their practice. Next slide, please. So now jumping over to the more law enforcement side. There are drug courts in Illinois. I included a map here. It's just one type of problem-solving court. So there's also veterans courts, mental health courts, but this map is specific to drug courts. Next slide, please. The Drug Court Treatment Act allows for drug courts in Illinois. They're supported at the federal and state level. It provides treatment as an alternative to incarceration. So if someone is arrested for a drug offense, they may be able, if they meet certain eligibility requirements determined by the local jurisdiction, they may be able to enter treatment rather than going to prison to actually try and get at the root cause of their criminal act. So it can be tricky deciding on those eligibility requirements, and it requires a lot of close supervision and monitoring to ensure the individual sticks to the treatment plan. And you really need to have the judges, state's attorneys, and probation all on board to make it successful. There are a lot of counties that have really successful programs in the state, and if you're interested in pursuing that, I'm happy to send you resources on how to talk to them. Other than the information here, this is not really my specialty. Next slide, please. There are also pre-arrest programs, which are called deflection. I listed a couple really good examples. Again, this is not an exhaustive list, but these are ones that I I've seen them speak, and I'm really impressed with what they're doing in Lake County and Lee County. I know Safe Passage is also available in other counties. The idea is that if someone has realizes that they have a problem and they want to seek treatment, they can go into one of these law enforcement agencies, hand over their drugs, and say, I want to go into treatment. Each one of these is going to treat it a little differently, and there's definitely some limitations. If there's an active warrant out for someone, I don't believe any of the programs say that they will not arrest them at that point. But it really helps reduce the fear of police, and some of these programs thought that they would have a big barrier with people not wanting to come into the law enforcement agency to seek treatment, but they've actually had a lot of people go through. I highly recommend looking at those two programs that I listed on here and finding out more information. I've mentioned, sorry, next slide, please. I mentioned naloxone a couple times. You may be familiar with it as Narcan. That's the one of the proprietary names for it. I included a couple pictures here. The one on the left is Evizio. That's an auto-injector, kind of like an EpiPen. And on the right is a picture of Narcan, which is a nasal spray, kind of like an allergy spray. It's a very safe drug. It's easy to administer correctly, and it's extremely effective. So if you come across someone who has overdosed on an opioid, you can administer this drug without fear that you're going to accidentally give them the wrong thing. If they don't respond, if they're not actually overdosing on opioids, then it will not harm them. IDPH also released a standing order recently that allows pharmacists and what we call OEND programs, opioid overdose education and naloxone distribution programs. They can provide naloxone without a prescription. They're still considered prescription drugs, but essentially there's a blanket prescription for them that allows the pharmacists in these programs to distribute the naloxone. Next slide, please. Drug take-back days are a really cool thing that the Drug Enforcement Agency sponsors twice a year. It's a safe and anonymous way to clean out medicine cabinets and turn in unused prescription drugs. It's usually in partnership with a pharmacy and local law enforcement. And I included the link takebackday.dea.gov to learn more about becoming part of that program. It's especially helpful when people have leftover opioid pain relievers from surgeries, and they may not want to keep it around, but it's hard to get rid of. So at these drug take-back days, they can bring it in and no longer worry that someone might accidentally get into the medicine cabinet and take it either by accident or on purpose. Next slide, please. I also wanted to talk about community education. A lot of people want to focus on educating youth, and I definitely encourage that. And I provided a link there for finding evidence-based programs that have been studied to see what's the most effective. So that link to SAMHSA will tell you what's involved, if it costs money. It's really helpful for finding those evidence-based programs. It's also a good idea to educate the community about proper storage and disposal of prescription drugs. So keeping them safe from children, keeping them away from people who might want them potentially locked up, and disposing them in the right way, either through a drug take-back day. There are other recommended ways, but in my opinion, it's best to take them to an official disposal site or event. The next thing that's good to educate about is Illinois Good Samaritan laws. So an individual cannot be charged with or prosecuted for possession for small amounts of illegal drugs. The amount depends on the type of drug. If they, in a good faith effort, seek emergency medical help. So there are exceptions to that, and there are restrictions to the amounts of drugs they can have on them. But the idea is if someone is with someone who overdoses, we want their first consideration to be saving that other person's life, not worrying about whether or not they'll be charged with a crime. So that is a really good thing that we have going on that I think a lot of people are unaware of. And then the last thing for education is that naloxone usage, letting people know about the standing order, encouraging family and friends of opioid users to obtain naloxone to carry in case they come up across their loved one having overdosed. Next slide, please. So the final thing that I wanted to bring up is stigma. This is something that you can address at the individual level, at the local level, at the state, federally. It's something we can all do to focus on encouraging people to seek treatment. Because historically, drug use has been framed as a moral failing. I mean, I grew up in rural Oregon, and it was during the height of the meth issues, and we were one of the hardest hit states. And I'm not going to repeat the words that people would use to describe meth users, but it definitely doesn't make you think of a brother or a father or a sister or a friend, that you think of them as an other and someone who has done it to themselves. And we don't want to frame it that way, because our main goal is getting people to live long enough to decide to seek treatment so that they can continue to live healthy lives after they've gotten off of opioids. So just a few tips for reducing stigma. First, when you're talking about people who use drugs, try to stay away from stigmatizing language, junkie or things like that. Even if that's what you're used to, even though you may have used that in the past, I'm sure most of us have at some point. If we can frame it as someone who has a problem, someone who has a medical issue, they may be less embarrassed, less stigmatized if they want to seek treatment later. Remind yourself that each person using drugs has a story that led him or her down that road. So some people have lived really rough lives. Some people may not have. When you talk to people who are currently in recovery, you'll hear a lot of different stories, and they're all different. But it's important to remind yourself that there's a reason that they started using drugs, and whether or not you would have made the same choice, it doesn't help to stigmatize it. Again, use medical terminology when possible, opioid use disorder, things like that. And also, something that's come up recently, I think, we've been trying so hard to deal with the opioid epidemic that we can forget that some people really do have a medical need for opioid pain relievers. We don't want to stigmatize them or make them embarrassed to do what they need to treat their pain, whether it's for an accident or cancer pain. We want them to be able to seek the medical treatment they need, just like we want people with opioid use disorder to be able to seek the medical treatment they need. And then finally, supporting those in recovery. There's a lot of ways that can take place. If you have a family member, there are groups similar to Al-Anon. I believe there's one called Narcanon. But there are groups that you can go to understand how to better support them. And next slide. Questions. I kind of sped through that. So I have plenty of time for questions.
So Heidi, what we'll do is we've been collecting the questions as they were posted in the chat box. We also copied the links that you provided, so if people are interested in saving those links to the resources you mentioned, those are also in the chat box, so they can see those without going back to the slides. But let's just get started on the questions that came up. So Nancy and I'll share this. If someone overdoses due to a high BAC plus, a cocktail of opioids, benzos, meth, etc., are those overdoses included in your data?
Yes. If they are tested positive for opioids at all, if they die, there are three separate data sources that I used for that. So first, vital records, that goes through the deaths. If someone overdoses, they're tested for opioids, they come back positive, and it's listed on the death certificate, yes, those are included in the numbers. There's some issues with testing. It's become more and more expensive as there have been more synthetic drugs. So we do the best we can with the data available, and the coroners are doing the best they can with the resources they have available. But yes, they are all included in that. For the ED discharge and the hospitalization data, if opioids are listed on their, I believe it's the discharge summary, whether they had other drugs involved or not, they are included in that data set.
Heidi, you mentioned treatment drugs. Are those treatment drugs expensive? What cost is associated with the treatment drugs?
So the cheapest one is methadone. I don't have the numbers available. I learned them last week from a physician here in Springfield. Methadone is very cheap. Suboxone is slightly more expensive. It is, I think, somewhere between $100 and $150 a month if you're paying for it out of pocket. And then Vivitrol, the injection, is the most expensive one. And that, I believe, is just above $1,000 for a month. But all of these are covered by insurance. Mm-hmm. So if someone has insurance, then they won't be paying that amount out of pocket. But in terms of the ranking the order of price, methadone is by far the cheapest, Suboxone slightly more expensive, and Vivitrol is much more expensive.
So Heidi, when you were talking about the medical assisted treatment, you also mentioned wraparound services. So how are those typically provided, and what are the costs, if you can estimate, for those wraparound services?
It really depends on what's considered in that grouping. It's kind of a catch-all term. So if you think about what an individual needs to succeed in a treatment plan, they need to be able to get to treatment. They need to have insurance coverage. They need counseling. They need a variety of different things. Anything that's considered reimbursable via insurance, so counseling, for example, they may be able to cover with insurance. The other ones, like transportation, is something, if there's a community organization that provides that, then they won't have as much of an issue. If they have a loved one or someone that can drive them to treatment, then that wouldn't be a price. But it is hard to put a cost exactly on there.
You mentioned the Good Samaritan law in Illinois. Is that offered or provided outside of our state, or is that just an Illinois law?
Sorry, can you repeat that? It got kind of muffled for a second.
Is the Good Samaritan law an Illinois only law, or are other states developing Good Samaritan laws?
So that one is specific to Illinois. There are Good Samaritan laws in a lot of states, but because it's a state-specific law, each one of them will have different provisions, and if, like in the Illinois law, there's a certain weight of substance. There might be a different weight of substance that is allowable in a Good Samaritan law in another state. But yes, a lot of states do have Good Samaritan laws, but I don't know offhand the surrounding states of Illinois.
When you were showing the maps, the question came up of why there's such a disparity in treatment and usage in central Illinois. Do you have any insight as to why that occurred?
The treatment is difficult because you have to be able to not only attract physicians that want to provide that treatment, but there also have to be enough physicians. We have a lot of health professional shortage areas in that whole area, and it's just one manifestation of that. I think also having a more rural population, people would have to be able to get to treatment, and often people who are affected by substance use disorder do have issues with that transportation barrier.
So you mentioned the help groups, Narcanon. Is that Narcotics Anonymous or Anon? Could you tell us again what that is?
So Al-Anon, which is, it's kind of like, I think it's, okay, so it's harder for me to describe the support groups for families, but Al-Anon is a support group for families affected by alcohol abuse. Mm-hmm. And I believe it's called Narcanon. If someone knows better, I am happy to defer to their expertise.
Maybe it's Nar-Anon, Nar-Anon. Somebody Googled it while you were talking. Okay, yeah, we've got it in the chat box. Okay, thanks you guys. Okay. Stephanie and Alita did some Googling and found it.
Yes, Nar-Anon. You're correct.
Gotcha. Okay, good to know. Let me ask you, and you guys, if you have other questions, keep posting them.
Zach. One of the questions was, we are examining the crisis from an economic perspective, the inability of a person to pass a drug test to get or keep a job. We are presuming the best way will be educating youth and early intervention. What are your thoughts on that?
I think that youth and early intervention is a really important thing not to overlook. For me, I deal a lot with overdose deaths, so my thought process is probably a little bit different when I'm looking at which age groups are most affected by opioids. There's a greater number of people who overdose between the age of 25 to 44 than any other age group. So that's immediately where my mind goes. So I think that if youth education is a possibility in your area, I think that is important. I don't know. I just don't want to color that with my extreme focus, I would say, on specific age groups.
Very good. The next question was, is Vivitrol covered by Medicaid?
Yes, it is.
Okay, very good. The next was, do you have the shapefiles for the 2 GIS maps that you displayed, or did you get those maps from an online source?
So the 2 maps for the ED discharge and the hospitalization I got from another person here at IDPH. The other map, there was a treatment map, and that was not an IDPH map, so I don't have that. But I'm not a GIS person. I'm learning how to use it now. But if that person who has that question wants to email me, if you can flip to the last slide, it has my contact information. I'd be happy to put you in contact with the person who created the maps.
Great. The next question was, how should we address concerns with misuse of opioids in relation to those coping with the impact of domestic abuse or current concerns with domestic violence?
That is a really good question that I do not feel capable of answering.
Fair enough. Where can departments access county-specific opioid overdose ER data and opioid death totals for 2014, 15, and 16? And are there any means for departments to access opioid data for 2017?
So in terms of death information, that's on the IDPH website, kind of buried a little bit. If you go to IDPH, then vital statistics and death statistics, more death statistics. Then there's a link to the deaths by county, separated out into all overdose, all drug overdoses, opioid overdoses, heroin, and what we call opioid analgesics, which again is just prescriptions and synthetic all together. So we have that 2013 to 2016. If you'd like more specific information, again, just shoot me an email. We do have access to the vital record system, and I'm happy to put you in contact with our vital statistician. For the ED discharge and hospitalization, we do have that by county. I am not sure if it's posted on our website, but again, just email me and I can send you to the correct link. We have something called the Public Health Community Map. If you Google IDPH Public Health Community Map, there's county level data, but I'm not sure off the top of my head what exactly is included on there. In terms of 2017, we do have the first quarter. We're pretty sure that our death data is correct and complete. From there, we're not entirely sure what the second quarter, it looks like it might have gone down, but it's also entirely possible that testing is just taking longer, and so we haven't released those numbers because they seem incomplete, but in the near future we'll be releasing second quarter of 2017 for the death data. Again, there's a delay because of the way that we process that death data and the way that coroner's investigations happen. But again, just email me with any specific data requests, and I'm happy to make that happen. We really do want to support what's happening locally, and that's one way that we can do that.
Great. We're going to keep the questions rolling, but I also want to mention that for folks who are still on, there is a poll question, and if you could just click right on your screen, it's asking whether or not you got something out of this program, and so if you could just take a second to respond, that would be great. And then also, a lot of participants are asking if we can send them your slide set. Would that be okay with you?
Yep.
Okay, great. So we will plan on doing that. And then to keep the questions rolling for the next few minutes that we have, what are some of the unique challenges that Illinois faces with the opioid crisis?
One thing that we struggle with is the fact that so much of the population is concentrated in one area, Chicago and the surrounding area, but there are a lot of people suffering from opioid use disorder in the more rural areas that have less treatment options available. Also, even within Chicago, while there are more treatment options available, it can still be difficult to get to those places. But I would say one of the biggest issues is the difference between urban and rural areas, and trying to create a sort of comprehensive statewide plan for such different places.
Great.
I have a question.
Go ahead.
Okay, you answered my main question was, will I be able to get these with slides. But I wanted to know, do you have a date as to when I actually would like to share that at a meeting that I'm having? How soon we could get them?
I mean, as soon. And the folks at U of I, do you guys have an answer? Because I'm.
It shouldn't take us more than a couple days to send the slides out, I would imagine.
If you need them faster, I can send them to you. Just shoot me an email.
Thank you.
Is there any effort underway at the federal level to make methadone more accessible, to loosen the restrictions?
I have personally not seen those efforts. It's not to say there aren't efforts that are underway. They just have not been advertised if there are.
Okay. Many rural populations have very conservative lifestyles and tend not to believe their communities have a crisis like this on their hands. What's the best way to address them?
I've found that maps are particularly helpful when you can compare what your county looks like to other counties. I live in a rural county, and I'm from a rural area, and I definitely see those issues. Actually, a little shout out to Schuyler County. They do recognize this as a public health issue and have been doing what they can to address the issue. So I think it's not impossible to overcome those issues, but if you use, I fall back to data. If you can show that your county is worse off than another county nearby, or if you want to show, your county is doing so well, you want to keep it doing well. You want to keep your numbers better than, people can get a little competitive, which isn't a bad thing in this case. If you don't have any opioid overdoses one year, and you want to keep that going, that is a wonderful goal. And I think it can be a good way to convince people.
Great. One of our participants said, I noticed we've talked about many alternatives, yet no one has discussed medical cannabis for pain management. Considering there are no known deaths for cannabis, when will the state of Illinois recognize medical cannabis as an option for pain relief?
I knew we were going to get that question. I appreciate it. I will bring it to. I'll bring it up at internal IDPH meetings. I'm a data person, so I do appreciate the data focus of the question too, but I don't have a true answer to that question.
Okay, then there's a follow-up kind of comment that just asked when are local health departments going to be contracted with as sign-up sites for medical cannabis program?
That I don't know. Again, it's outside of my division, but I'm happy to bring it up with that division and ask them.
Okay, and then it looks like we have one more question. It says, where does Illinois receive their funding? And I'm assuming it's in relation to this whole specific topic.
Yeah, so it comes from a variety of places. Some things, like we just received a SAMHSA grant. We're working with 18 counties in central and slightly south of central Illinois. So that money is coming from the federal government, and we've gotten a few grants from the federal government. There's also, because it's such a big issue, it just makes its way into the budget. So there is some state money that's directed towards it as well.
Okay, I didn't see any other questions in the chat box. Did anybody have any ones that they would like me to pose to our speaker? We have a question that said, would that be CDC or another federal agency?
So we got it through SAMHSA, the Substance Abuse and Mental Health Agency. There are the CARA funding, the Comprehensive Addiction Recovery Act funding, is coming through a variety of federal agencies. So it's not just one agency. There is CDC funding that we get for various issues. I'm not aware of specific CDC opioid funding, but again, that's just my experience in my small division, so it's entirely possible that we do get it. But I am aware of SAMHSA specifically.
Okay, great. Any other last-minute questions? Well, I'd like to take the time to thank Heidi. It was a great presentation, and it's a very important topic, and it seems like folks are definitely going to want to see your slide set, so that's always a good sign that it was good information presented, and we really appreciate it. It was a well-attended webinar, and again, thank you, and we appreciate you presenting this information.
Well, thanks for having me, and I just want to emphasize again, if anyone has specific questions or wants to be directed towards any data sources or resources, just shoot me an email, and I'll do my best to get back to you as quick as I can.
Thank you very much. And attendees, we will try to get the slide sets out to you as quickly as we possibly can. And also, Nancy has posted links to our LGE archive in the chat. So if you want to check out some of the recordings of our previous webinars, as well as find information out about our upcoming webinars, you can visit that site.
All right. Thank you again.
Thanks, everybody.
Have a good day.
You too. Thank you.
Bye.